So today's session, we're going to look at supraventricular tachycardia. And when we say supraventricular, we mean anything above the ventricle. That's supra. So we have ventricular and supraventricular. So tachycardia, any heart rate greater than 100, which is above the ventricle. Now, when we talk about supraventricular tachycardia, we have a lot. So it's common when you go to the hospital and the the hospitalist says, well, this patient has supraventricular tachycardia. It really doesn't mean anything to me because it's a whole gross of fast heartbeat that we lump together. So it's you should always separate them out, and because the treatment of the different types of supraventricular tachycardia differs. So again, when we say supraventricular tachycardia, is tachycardia that originates above the bundle of His. The most common type is what we call AVNRT, and that is basically AV nodal reentrant tachycardia. So that's a reentrance circuit.
Dr. Smith,
Yes. Oh, you're not seeing, right? Okay.
I can't see. I can't see anything.
Okay. All right. So when we say supraventricular tachycardia, it is tachycardia above the bundle of His, and one of the most common type is AVNRT. That's atrioventricular nodal reentry tachycardia. Atrioventricular nodal reentry tachycardia. That's the most common type, and there are two types. One is the classic, and the other one, or the typical, and the other one is the atypical. We I'm not gonna burden you with the classic mechanism. We're not gonna burden you with that, but basically when you look at AVNRT, the classic type, you see that there's a P wave just after the QR, or sometimes the P wave is buried in the QRS. So it's a very rapid heart rate, and the beat is above the bundle of His, and the P wave is usually in the QRS or just outside of the QRS. Okay, so it is relatively easy to diagnose. So again, there are two types, the classic and okay, so you have the common type and the uncommon type. The thing about AV nodal reentry tachycardia, the rhythm is a regular one. So they used to call it PAT, but the current designation is AVNRT, atrioventricular nodal reentry tachycardia. So it's a rapid heartbeat coming from above the AV node in the atrium someplace. The narrow complex, okay? There's a common type where the P wave is probably in the QRS or just a little bit after the QRS. And then the uncommon type where the P wave is very far away from the QRS. And this uncommon type sometimes looks like a sinus tachycardia. All right, so the heartbeat. So this would be the uncommon type where the P wave is somewhat far away. This is the P wave. You see, they're highlighted P waves. They're some distance away from the QRS, and sometimes you can mistake that for um, for sinus tachycardia. So that is why when you have these type of rhythm, abnormal rhythm, it's best you'll get a specialist to look at it. And then this is what we call AVNRT, where you have these wide QRS. This atrioventricular reciprocating tachycardia, AVRT, it means atrioventricular reciprocating tachycardia. What happens is sometimes we have what we call bypass track. So bypass tracks are specialized tracks that it bypass the AV node. So these are specialized tissues that instead of the impulse going down the AV node, because remember what we said, when the impulse goes down the AV node, it slows. These bypass track, they goes around the AV node, and as a result, the electrical impulse quickly it travels from the atrium to the ventricle. That can be dangerous. So that can be dangerous. And you must have heard about WP Wolff Parkinson White syndrome. That is a type of bypass track. So with this AVRT, so the first one we look at was AVNRT, which is different from AVRT. AVRT is atrioventricular reciprocating tachycardia. So what happened is the impulse coming from the atrium travels down the AV node, but it goes up back into the atrium via the bypass track. So this just can be dangerous as well. So you just know that it exists. You don't have to, All right. So the type of supraventricular tachycardia that you may be familiar with is atrial flutter. And when we say atrial flutter, it's basically an abnormal foci coming. Usually there's an area close to the tricuspid valve that these flutter usually comes about. And when you look at the atrial rate, that is the separation of the P to P interval, the atrial rate is usually between 250 and 350 beats per minute. But the ventricular rate is usually some factor of this, probably half of it, 1/3 of it, or 1/4. So we usually talk about a ventricular rate, which is probably 4-to-1, 3-to-1, or 2-to-1 blocks. The thing about atrial flutter, when you look in leads 2, usually the P waves are usually sawtooth. We'll talk about a negative sawtooth. So if you see it, you'll probably remember it. So this is our 12 lead ECG. Of course, you have lead 1, lead 2, lead 3, AVR, AVL, AVF, and then V1, V2, V3, V4, V5, V6. But if you just take out lead 2, you can just look closely at lead 2. These downward deflection are P waves. These downward deflection are P waves. And you can see that the P waves are very regular. They're very regular. And you can see that the separation of each P wave is about one big block. So the rate, remember, the rate is 300 divided by big blocks. So if you want to calculate the atrial rate, then it's 300 divided by one big block. So the atrial rate is 300. So the atrium is contracting very, very fast. But look at the ventricular response. You see the ventricular response is not as fast. Okay? It is relatively slow. It's irregular though. Okay, so this is what we call atrial flutter with variable AV block. So atrial flutter with variable AV block. A lot of times you'll get atrial flutter with what we call 2-to-1 AV block. So for every 2 P waves, you'll get 1 ventricular beat. But you can see that this is very irregular. So this is atrial flutter with variable AV block. So this is what we call the negative sawtooth pattern. The negative sawtooth pattern. You can see the P in leads 2, the P waves are negative. They're below the baseline. That's why we said they are negatives. So negative P waves, and you can see that the separation of the P waves is one big block. So the atrial rate here is 300 beats per minute. All right, so this is your atrial flutter with 2 to 1 AV block. So let's look at our lead 2. Lead 2 is right here. You can see these downward deflections are your P waves. Downward deflections are your P waves. And if you look closely at it, you have 2 P waves to a QRS. 2 P waves to a QRS. So this is atrial flutter with 2 to 1 AV block. So every 2 atrial rate, you have 1 ventricular rate. And of course, you can see the negative P waves in leads 2. That means it's below the baseline. So this is lead 2, a rhythm strip with lead 2. You can see the P waves are below the baseline, negative. Okay? So, and again, if you look closely, the separation of the P waves is a little bit more than a big block. Probably, you can just call it one big block. So the atrial rate here would be 300 divided by one big block. So it would be 300. And look at the ventricular rate. A P wave, sorry, a QRS is there, a QRS is there, a QRS is there. You see, there are actually about 2 big blocks separating the RR interval, right? There are about 2 big blocks separating the RR interval. So the arc rate there would be 300 divided by 2, so 150. So the atrial rate is 300, and the ventricular rate, because the R to R interval is basically the ventricular rate. The ventricular rate is 150. That is why we say it's a 2 to 1 AV block. Every 2 P waves, you have a QRS or R wave. Okay, so this is classic atrial flutter, which is different from atrial fibrillation. I'm sorry, this is very rare, very rare. Atrial flutter with one-to-one conduction. It's not one-to-one block, but one-to-one conduction. So for every P wave, you have a QRS. Every P wave, a QRS. Every P wave, a QRS. But look at the R to R interval is one big block. So that ventricular rate is 300 beats per minute. This patient will be passing out. Okay? This patient is going to pass out. And if nothing is done, they can probably degenerate into ventricular fibrillation and death. So this is something that has to be treated urgently. This is actually a patient of mine. Okay, so this patient, you have to treat them urgently because it's atrial flutter with one-to-one conduction. All right, so we're going to look at atrial fibrillation. Atrial fibrillation. This is extremely common. Extremely common. So you have to know what atrial fibrillation looks like because these patients is going to come to the echo lab. The electrical impulse usually originates around the root of the pulmonary veins. So the electrical impulse usually originates around the root of the pulmonary vein. The ventricular rate are usually irregular. There is no regularity to the ventricular rate. It's irregularly irregular. There's no discernible P wave. You cannot make out any P wave. The baseline is usually very irregular. And again, the R to R interval is going to be very irregular, irregularly irregular. So this is a classic atrial fibrillation. Let's take out lead 2. Okay, none of these R to R interval are the same. None of the R to R intervals are the same. They all differs. And you just look at it. This one is different from this, which is different from this, which is different. It's irregularly irregular. And when you look at the baseline down here, you don't see anything looking like P waves because there is no P waves. The top of the atrium is quivering. It's actually beating sometimes 600 times a minute or more. So you don't see any P wave. Okay? So this is classic atrial fibrillation. And you can see the R to R interval varies. Okay? So this is atrial fibrillation with rapid ventricular response. Okay? All right. And we talk about ventricular tachycardia at the last session. Ventricular tachycardia, the rapid rate comes from the ventricle, which is below the bundle of his. It's a tachycardia that originates in one of the ventricles. The heart rate is usually greater than 100 beats per minute. We say it's sustained if it lasts for more than 30 seconds, and it's non-sustained if it lasts for less than 30 seconds. Because it's coming from the ventricle, the QRS is going to be wide and bizarre. It's going to differ from your atrial fibrillation. The R to R interval is going to be very regular. So ventricular tachycardia will look something like this. It's going to be wide and bizarre, but if you check the R to R interval, okay, they're going to be the same distance that separate them. But it's wide and bizarre. It's dangerous still. Ventricular tachycardia is a dangerous rhythm. These patients can degenerate into ventricular fibrillation. Ventricular fibrillation usually causes death. So this is ventricular fibrillation. It's an uncoordinated contraction of the ventricle. The ventricle quivers. So therefore, the brain is not going to get any blood. None of the organs are going to get any blood, and the patient dies. So when patient, most of the time when patient dies, they die from ventricular fibrillation. Okay, again, an uncoordinated contraction of the ventricles. And it looks something like this. You see, this just totally chaos. Okay, there's no regularity to this rhythm, and this usually kills patients. Okay, so we're going to stop here, and we will probably do a few more sessions an ECG, but on Saturday, we're going to start our scanning views. We're going to start scanning views. So Saturday, Monday, and Thursday, we should complete scanning views. So by next weekend, you guys should be scanning. Okay?